Hello everyone, welcome to my channel. Next topic about eye disorder is retinal detachment. Let's get started with the topic. We shall start with the introduction part. Retinal detachment is a disorder of eye in which retina separates from the underlying supporting tissue. To separate, retina has to peel away from the underlying support tissue. This condition might result in vision loss. The incidence of retinal detachment is 5 new cases per 1 lakh person in a year. It is more common in patients with myopia in whom retina is thinly stretched. So when retina is thinly stretched, it is easy to detach from its original layer. Detached retina looks somehow like this. It breaks down from its attached layer and gets detached downwards. Following are the types of retinal detachment. They are Rhegmatogenous retinal detachment, Tractional retinal detachment, and Exudative retinal detachment. In Rhegmatogenous, there is a breakdown in retina. After breaking, retina divides itself into holes, tears, and dialysis that can be seen during examination. In exudative, it occurs due to inflammation, injury, or vascular abnormalities. After injury or inflammation, fluid accumulation occurs underneath the retina without presence of hole, tear, or break like the previous one, Rhegmatogenous one. In tractional detachment, it occurs when fibrous or fibrovascular tissue pulls the sensory retina from retinal pigment epithelium. So here there is no hole tear, but the fibrovascular tissue pulls out sensory part of the retina. Risk factor of retinal detachment are severe myopia, retinal tear, family history of retinal detachment, eye trauma or injury, tumors of eye, cataract surgery. People suffering from one of these or more than one of these can suffer from retinal detachment. Clinical features can be blurred vision, seeing a shadow or curtain descending from the top of the eye or across the eye. Warning signs can be flashes of light, photopsia, and the sudden increase in number of floaters. The floaters which were originally appearing, just appearing, if it is increased in number, that is a warning sign. Next is painless loss of peripheral or central vision. We can diagnose this disease first of all by history taking. History taking should be done starting from chief complaint, present status, and then trauma history, previous any ophthalmic surgery if done, or previous uveitis. Uveitis was our previous topic. If there is a history of uveitis, there are chances that retina might get detached in the long term. In physical examination, we should check visual acuity. There should be external examination for sign of trauma. Assessment of pupil reaction should be done. Examination of vitreous for a sign of pigment or tobacco dust can also be done because this detachment can occur also due to presence of foreign body in the eye. Next is measurement of intraocular pressure. We had a topic about measurement of intraocular pressure. Measurement of intraocular pressure will help us to determine whether eye is suffering from any kind of strain or not. Slit lamp examination can be performed to find out the actual site of the problem. Ophthalmoscopy can be done for detailed visualization of all the organs inside the eye. Now is surgical management. Surgically, we can repair the tissue by cryoplexy and laser photocoagulation. In cryoplexy and laser photocoagulation, freezing is used to wall off a small area of retinal detachment. To freeze, Nitrous oxide is used, and the freezing is done to the tissue behind retinal tear. Next is scleral buccal surgery. Buccal is a cavity, man-made cavity. In this process, silicon band is placed to the sclera to push the wall of eye against the retinal wall. Pushing wall of eye against the retinal wall will provide a support to the retina. Scleral buckles can be done radially, circumferentially, and incircally. Next is pneumatic retinopexy. This is done under local anesthesia. Gas bubble SF6 of C3F8 gas is injected into the eye, after which laser or freezing treatment is done. This process is generally combined with cryopexy or laser photocoagulation. That means this process should be combined so that air can be inserted and photocoagulation, light treatment can also be done. Next is vitrectomy. We can make an incision in the sclera and remove excess fluid so that the excess pressure to the retina can be reduced. Nursing management can be divided into preoperative and postoperative management. In preoperative management, first of all, visual acuity can be monitored so that we can obtain a baseline data. Assessment of impact of impaired vision can be done so that we can gain knowledge about patient's lifestyle previously and the changed lifestyle due to this disorder, eye disorder. All the eye makeup should be removed before the surgery because use of artificial products might interfere the surgery. Mydriatic or cycloplegic drug can be provided so that intraocular pressure can be reduced. For post-operative interventions, first of all, status of the eye should be monitored so that we can monitor the outcome of surgery. And then presence of bleeding should be assessed. Bleeding and drainage is a sign that there is some problem which should be managed immediately. Patient should be placed in semi-Fowler's position so that intraocular pressure can be reduced. Also, patient should avoid coughing, sneezing, or straining. Coughing and sneezing can be occurred if the patient has a viral infection. Straining can occur due to constipation. All these can be stimuli which can increase the pressure in the eye. So that should be reduced. Ambulation of the patient should be assisted because the patient's vision might be impaired till few days. After few days, when the patient is able to walk independently, then patient can perform self-care. These were the nursing management. Now, complications of this disease can be, first of all, redness of eye, continuous redness, continuous swelling of eye, itching of eye, and blurred vision. Thank you. Next topic will be discussed in next video.